Here's a message from today's episode's sponsor.
Have you heard about Prescriptive Health? Prescriptive is a healthcare technology company rewriting the script for the U.S. prescription market. This is a first in pharmacy. The Prescriptive platform enables pharmacies to connect with their patients in a more equitable and transparent ecosystem, which will foster fair pricing, better access to medication, increased adherence, and, most importantly, better patient engagement. The Prescriptive team believes in empowering healthcare consumers with easy-to-use tech to fundamentally change how prescriptions reach and impact the lives of people throughout our nation. Join Prescriptive Health in rewriting the script. Learn more at prescriptive.com.
You're listening to the Pharmacy Podcast Network.
3, 2, 1.
Adverse drug reactions, or ADRs, are a serious issue in healthcare today. The pharmacist is the last line of defense to help prevent ADRs. A rising role of the pharmacist is the specialist who focuses on our children. Pediatric pharmacy ensures safe and effective drug use and optimal medication therapy outcomes in children up to 18 years of age. Currently, there are more than 1,450 board-certified pediatric pharmacy specialists, known as BPS. If you're interested in this expanding field of pharmacy, this podcast is for you. All right, everyone, let's give it up for our host.
Okay, hi everybody. Thank you so much for joining us. This is the Pediatrics in Review. We are part of the Pharmacy Podcast Network, and I am truly honored to have Stephen here today, Stephen Teach. He is a physician who helped write the much needed and long overdue guidelines. The 2020, I was so excited about this, National Asthma Education and Prevention Program. He was part of their coordination committee and expert panel that helped give us some updated guidelines to the 2007 asthma guidelines. So I know as a pediatric pharmacist, I was really excited to have this because 2007 in medicine timeline and terminology is a really long time. And I'm really just happy to have you on because I know a lot of these things that are highlighted in the guidelines are a huge change in practice for a lot of us providers. And so again, thank you, Stephen, for being on. First and foremost, I would just love you to introduce yourself a little about as we started talking about before I hit record, what you do and what your mission is. And again, thank you so much, Stephen.
You bet. It's a real pleasure to be with you, Jenna. I'm really excited to do this. My name is Stephen Teach. I'm a pediatrician and a pediatric emergency medicine doctor at Children's National Hospital in Washington, D.C. I run a program that I actually founded it over 2 decades ago.
Wow.
It's called Impact DC for Improving Pediatric Asthma Care in the District of Columbia. It's a matrix program, actually, of asthma care, advocacy, research, and education. And it has a kind of a broad focus of improving the care and outcomes of kids largely from under-resourced urban backgrounds, many of whom are Black and Hispanic and have limited access to effective longitudinal modern asthma care.
Mm-hmm.
Many of these children are highly dependent on the urban emergency department. So on the emergency department of our hospital, for example, for episodic care of asthma. So these are the kids that are home, exposed to a lot of allergens, indoor particulates, nitrogen dioxide from the gas top stove, all those irritants and allergens, trigger their asthma, particularly in the setting of a viral upper respiratory infection. And they head into the emergency department where we hit them hard with albuterol and ipratropium and systemic steroids, magnesium, epinephrine if we need to, and we rapidly turn these exacerbations around. And we're really good at it. Our admission rate in the emergency department hovers around 15 to 20% of all the kids that come in. Most of the kids are treated and they go home.
Wow.
The problem with that, Jenna, though, is obvious that the families come to depend on that care source. And because of their limited access to really effective longitudinal care, they end up sort of cycling from no care in the community to our intensive emergency department-based care. And they don't avail themselves of the, what we all know was the effective ongoing longitudinal care. I like to say a whiff of inhaled corticosteroid goes a long way to calming down the airways and keeping the kids under control. So that's what we do. We partner with these families in a matrix program of care, advocacy, research, and try to bring the preferential options to them.
That's amazing. Thank you, Stephen. And I can say I know we talked a little bit about perfecting peds before, but that was one of the huge drivers of why I started my business, because we, just like you, I practiced for 8 years prior in Camden, New Jersey, which, as you know, is one of the most impoverished areas, just right, similar to DC. Their demographics are very similar, large Black and Latino. And I think there was such, again, that lack of health equity that we all talk about, but based off of their demographics, their poverty, their location, their income, these kids were frequent flyers, and I worked predominantly in the ICU. So I would get the really sick ones that were frequent flyers that were really scary, that you had your ketamine, your turb, these ones were so sick that they were intubated, but they would turn around so quickly. And then you would see them again, right, months later. And it was one of those things like, these kids are going to die. And so if we don't get them the appropriate access, and then, you want to pinpoint it on the parents, but then when you talk to them, it's like something as simple, which literally happened to my daughter, something as simple as that it's not, their meds aren't covered by the insurance company, and that they didn't communicate that to anybody. And for that reason, they have been non-compliant. I mean, my own daughter's Flovin, I think is still sitting there, because luckily hasn't needed it, but I think it's $400. And so just doing that simple formulary change to partner and match their insurance company, because the parents, nobody stressed to them the importance and the need of this inhaled corticosteroid, and then the fact that it's too pricey for them to afford, then that's really the root cause. And so working, just like you're saying, with these parents to get to, is it an education thing? Is it a financial thing? Is it, how can we help you and your child stay safe? And so thank you so much. I mean, seeing it every day in and out in the PICU setting, especially with those really scary kids, I can totally appreciate what you're doing, and 2 decades, and that's a huge project. So thank you. Getting into a little bit about the actual the asthma updates. Like I said, in 2017, as providers, as a pediatric pharmacist, I live and die by guidelines. Obviously, I know each patient's different, but it just gives us a great objective starting point. I just want to dive into the actual expert panel and working group, and wanted to see who sat on your panel, Stephen, as you were developing these updated guidelines.
Right. Yeah. It was a long process. And as you noted, it was really the first update since 2007. And when you think about that, it's a really remarkably long time given the advances we've seen over the last decade. So the National Heart, Lung, and Blood Institute has a group that's called the Expert Panel Working Group. And that's part of the National Asthma Education and Prevention Programming Coordinating Committee. So a big group of people, and they asked a number of us, mainly academic types, so people who were really comfortable reviewing and grading the existing literature in a number of areas. They recruited from across the country, pediatricians, internists, allergists, pulmonologists. I was actually a bit of an outlier as a pediatric emergency medicine doctor. But my interest has long been on exacerbations, flare-ups of the disease, and they actually valued that. And I was privileged to join up. It was a long process. It started with an exhaustive literature review, a generation of proposed questions. There was a public comment period where the public and professionals could comment on the proposed questions. And ultimately, there were 6 topic areas, only 6, which the group decided to focus on, 2 of which are really sort of pharmacy heavy.
Yes.
The 6 areas are the use of intermittent inhaled corticosteroids, the use of long-acting muscarinic antagonists, what to do about indoor environmental allergen exposures, the role of immunotherapy, the role of the measurement of fractional excretion of nitric oxide, and the role of bronchial thermoplasty, which is decidedly not used in pediatrics. So ultimately, they made 19 recommendations across these 6 areas, 18 of which are relevant to children and families uniquely. I'll mention right at the start, though, Jenna, what's really kind of interesting about these is what's not included on this list, right? And what's not included is what's really rocking the asthma world right now, which are the biologic therapies.
Yes.
The story there is that when the decision was made to update these topics way back in 2014, and this whole multi-year process unfolded,
Wow.
there was only a single biologic approved for use at that time, and that, of course, is omalizumab, which has been around the longest.
Yes.
Since then, we've had 4 or 5 more come online. But these focused updates, the 2020 focused updates, are absolutely silent on the role of biologics, and they've received a lot of criticism for that.
And that's interesting to me because omalizumab, I feel like too, even as a pharmacist, that comfort level, once you're going to those types of therapy, I feel like you need more guidance, right? Because then you're thinking of doing, all your IgE and IgG testing and how have they been exposed to steroids lately? Have they not? All those things are super complex. And so, you appreciate guidance as it gets into that. But that's just really shows that the need for these guidelines. And I had no idea that you guys started in 2014. It
was a multi-year long process. And then, right at the end of it, of course, COVID made the last several months, the process of the last several months, particularly tough. One other thing I think we should get out right at the beginning is, that these 18 recommendations affecting children are really broken into 2 groups.
Okay.
One is the strong recommendations. So those are, what we would, most reasonable doctors would, recommend for most patients as kind of the standard of care. And there were actually not very many strong recommendations made. Most were conditional recommendations, and these are intended really for most people, most patients, but the emphasis here is on this concept of shared decision making, involving the clinician, of course, the family, and of course the child, him or her, or their self. The idea being that this is going to be a discussion, like here are the options. What makes sense for you?
Yes.
As a clinician, I could go either way here. Let's get that input from the child and the family.
Yeah, and I think that's so critical too. And that's like a kind of an art as you get more into your practice is like, you kind of see that there's a lot of gray areas and it's not everything's black and white, and working with the family to see what's realistic for them from just a compliance standpoint, financial standpoint, and really to include them into the care really helps everybody all around, and so that's why I love working with these families really intimately. So, and what are the, I want to see if you could break down, because this is a huge, these updates are a huge change in practice from 2007, because just focusing on the inhaled corticosteroids alone, like I know traditionally as a pharmacist that graduated in 2012, they were saying like, if you don't take your inhaled corticosteroid every day, it's not even worth it, right? So we just like drilled into parents the importance of taking it twice a day. If you're not compliant, 80% of the time, don't even bother doing it because it's not going to work effectively. And so this intermittent inhaled corticosteroid really just was a huge practice shift. So I wanted to see if you could just break down the key points of change recommendations per age.
Yeah, I'll do my best. It gets really, really nuanced. And Jenna, I think that there's been a little bit too much made of, I think, in my opinion, of the guidelines recommendations around intermittent inhaled corticosteroids. Particularly what we'll come to in a minute, which is this real revolutionary idea of SMART therapy, the single maintenance and reliever therapy. It is true that the initial approach for most kids should continue to be daily inhaled corticosteroid in the lowest possible dose that controls them. And we should stress not only daily adherence, that is, take the med, but also proper technique, and that's the huge part about these inhaled steroids. I tell my families all the time that, any fool can take a teaspoon of Tylenol, right, and swallow it down. Not a lot of technique involved in that, right?
No.
But for a child in a family to properly take inhaled corticosteroids, whether by a meter dose inhaler or by a dry powdered inhaler, that's something that really needs to be taught, practiced, reinforced over and over again, because I talk all the time about technique and adherence, and I put technique first,
right?
Because you can be adherent to these drugs,
Very
but
true.
if you're not taking them correctly and getting them down to the small to medium-sized airways where they need to work, then you can be super adherent and still not really realize the benefit of the drug.
Yeah, and I think.
But go ahead. No, sorry.
No. I was just saying for my own personal, like with 3 little girls, my one has asthma and allergies, and really for me, nebs do not work because she can't sit still for a long enough time. And so really working, I had to actually plead with her provider to give her albuterol HFA with the spacer instead of the nebs. As you know, as an ED doctor, that the newer literature showing it's just as effective, if not more, that HFA with the spacer versus sitting there with the neb. But she had it it was for me, I'm like, it's not realistic for my kid to sit there. She's just too antsy. So I think too, like you're saying, that technique, that wasn't an option for my child and my family. So I'll let you take the stage, but wanted to just add that little bit.
And I'll reinforce that point so strongly. Our team feels strongly that first line should be the meter dose inhaler over the compressor and nebulizer.
Agreed.
Nearly 10 times out of 10, with a caveat that the family is trained in proper technique. The advantage in the nebulizer with the compressor, of course, is that technique is not as important. If you set it up properly, put the child on a mask, or give them the mouthpiece with the extension to use, and they'll sit there and take the entire treatment. That works pretty well.
Yeah.
It takes a long time. Got to keep it clean. There's a problem if you're traveling. A problem if you don't have access to electricity, of course. So we think that the meter dose inhaler with the spacer is a huge improvement. But again, it has to be taken correctly.
Yeah.
And you have to dispel this myth that a lot of the families have, and I call it the Harry Potter myth. And the Harry Potter myth is there's something magical about that mist, and I point out, hey, that's 99.9% saline is floating around there. So let's talk about getting the medicine to where it needs to be and the advantages of the meter dose inhaler and spacer. But hey, let's talk about intermittent ICS. Really three ways that the guidelines talk about intermittent ICS. The first is in the youngest kids, those kids 0 to 4 years of age, those kids with intermittent asthma diagnosed. And this is the group, where studies have shown that daily ICS, not super effective in preventing the flare-ups with these kids. So instead, what is now conditionally recommended is a short course of daily ICS, 7 to 10 days, with the as-needed short-acting beta agonist, albuterol, at the start of a viral infection, so a viral URI. And this recommendation applies to those kids who've had 3 or more lifetime episodes of virally induced wheezing, or 2 or more in the past year, and who are really asymptomatic in between.
My daughter. Yep.
Well, I'm glad you're applying the guidelines.
Yep.
Guidelines.
Yep.
And families like this, actually, because it gives them something very concrete to do for their kid, and they can start it really. The clever ones start it when the kid gets a viral upper respiratory infection and starts to cough a little bit. So they don't wait until the respiratory rate goes up, their retractions, the kid is wheezing. They start it early.
Yep. Or not, they're going to end up on oral steroids, which I know we'll talk about. But
no, anything but
that was what was happening. And I was like, no. Like after a second course, I'm like, oh no. And then these guidelines came out and just validated my thoughts as a mom. But they're not. Those whopping doses of Decadron are not benign.
No, they're not, particularly when the families are getting 3, 4, 5 courses of them a year.
Mm-hmm.
So we need to do more. The second recommendation for intermittent ICS is pretty narrow. It applies to those 12 and up with mild persistent asthma. And this gives clinicians and the families and the kids the ability to sort of jointly decide, so it's a conditional recommendation, jointly decide whether to replace their daily ICS with as-needed SABA with short courses of as-needed ICS with SABA. So this is the idea that, kids who are reasonably well controlled on their daily ICS with as-needed SABA can actually say, hey, let's just sort of take it only on an as-needed basis. This is particularly valuable in those families who really struggle with adherence,
right?
With the daily ICS. And so this is an option. And of course, these kids need to be closely monitored as they come off that daily ICS, and families need to be re-educated. And, for all these years, we've told you that daily ICS is required. Now we're going to say, okay, we're giving you permission based on good literature to think about using it. If you think it's a good idea, conditional recommendation to use it on an intermittent basis over daily ICS. I should say, just to interject here while we're talking about daily ICS, is that the committee did feel strongly that short-term increases in the daily ICS are not recommended at the onset of wheezing. So this idea of doubling, tripling, or even quadrupling the daily ICS is not recommended.
I've seen that, Stephen, in a couple of my local providers. Obviously, I've been giving them a call. But I saw that in a couple. And then that obviously took me back to rereading your guidelines and making sure I'm not missing anything, am I? Because, intuitively, you would think maybe it would work because, you're giving no inhaled corticosteroids, then you're giving some and it's working. But you think maybe it would work. But thankfully for your guys' recommendations and the expert panel to know that it does not is very, very important.
Certainly the biggest change, and the one that's, I think, garnered the most attention, in the asthma community nationwide, is SMART. It's all about SMART these days: single maintenance and reliever therapy. And that's treatment with ICS and a very specific LABA, formoterol, for both daily and rescue therapy. It is strongly recommended. So this is one of the few strong recommendations of the committee
Okay.
as the preferred therapy for kids ages 4 and up. 4 and up. So we take this all the way down to the little guys who are not well controlled on lower medium dose daily ICS alone. So first of all, this is what you do when they're not well controlled, right? And a couple of things. Why formoterol? Well, it's the lab of choice because it has two properties. It has a rapid onset of action, and it can be used more than BID. So that's kind of a double win where SMART kind of reduces exacerbations and reduces overall corticosteroid use. So the idea here is that you're taking your daily ICS LABA. You start having some breakthrough cough, wheeze, shortness of breath, and you start using the ICS LABA every 3 to 4 hours through the course of the day. It has a broad steroid sparing effect, and it reduces the total exposure to ICS over a step up, and the effects on growth rates in young children. Of course, it also has the added advantage of being only one device, so you don't need to, be juggling 2 inhalers, one with the daily ICS LABA and one with short-acting beta agonist. Challenge, the sort of elephant in the room with this is insurance coverage, right? Yeah. So the insurers love to give only exactly what you need.
Yep.
Right. And the traditional way that ICS LABA has been prescribed as a 30 or 90-day supply so that you can get your Q-day or BID inhalations. This kind of turns that on the head, though, and said, is asking insurers to provide for additional metered dose inhalers or dry powdered inhalers containing ICS and formoterol, so that it can be used for quick relief or for as a reliever as well. And so that's an insurance challenge.
Yep, they gotta love them. Prior, peer-to-peer, the whole nine. Now with this, I remember it clear as day. When I was rounding, I was a resident. And the pediatrician talking about how, only a pulmonologist should be prescribing a LABA, and LABAs have, the sudden cardiac death as one of their, it could cause sudden cardiac death. And she scared the crap out of me, for lack of a better words, when it came to LABAs. So I would love your input of what side effects you're seeing. If you're seeing any, obviously they wouldn't put these guidelines there loosely. And just, what would you say to a pediatrician to get them a little bit, because we have pediatric pharmacists, but pediatricians too listening, what would you say to just increase their comfort level of prescribing these medications without a pulmonologist, which sometimes is needed?
Yeah, I would green light the use according to the STEP guidelines, of course, with a caveat that the LABA never be used alone, but only in conjunction with the inhaled corticosteroid, where it's universally considered to be safe.
Cool. Yeah, I remember so old and green to me, and definitely scared. I know our residents, this is not something that they were comfortable with traditionally. Once that the LABA was talked about, that was when, nothing was done until they saw the pulmonologist. As far as Stephen, the just categorizing asthma, I know you've alluded to, mild, moderate, severe. Did the guidelines change at all and how we categorize them? Okay, I didn't think so.
No, it didn't. We still have those same definitions.
Okay.
They pulled through from the 2007 updates.
Awesome. Okay, I think that's really important for them to know. And then in these updates, I know we talked about SMART therapy, but was there a changing role in montelukast, or was that the same? How do you feel like, and this is even me as a pediatric pharmacist, when do you feel like that addition is appropriate, and what did the expert panel think?
The expert panel is silent in the 2020 updates on montelukast. It was not addressed. Practically, I use it sometimes in lieu of a step up in kids who are having a little bit of breakthrough symptoms, but not much,
Okay.
and in whom concomitant allergic rhinitis is prominent. Because it, of course, is labeled for that as well. So I tell the families, this is kind of a twofer. We're going to hope it's going to do a little bit for your asthma and a little bit for your allergic rhinitis.
Okay.
And use it that way.
And I think too, I mean, my own daughter, obviously Flonase is a great choice too for allergic rhinitis and that awful like post-nasal drip that a lot of kids get that cause them to have these coughs. But for me, you know what, Stephen, in practice, I've seen more and more neuropsych changes with montelukast that kind of scare me away from it. And I don't know, I mean, we know that it's definitely a possible side effect, but just recently, it's just weird. I had 2 kids in the past year that have experienced that. So just an adverse effect, not to not use the drug, but just be cognizant that when you do add it on, that could be a possible effect.
And we will talk to families about that and ask them to keep a close eye on.
That's awesome. That's awesome. Okay, so then what is, now it's place in therapy. This is new to me from just in general, my practice. What is the place in therapy for long-acting muscarinic antagonists? And how can we incorporate those into our practice in a stepwise function manner, I should say?
Yeah, pretty narrow for kids. The add-on LAMA therapy, these recommendations from the panel only apply to kids 12 and up.
Okay.
So I believe LAMA therapy is approved on to age 6, but that was not considered, that age group, the 6 to 11-year-old age group, not considered as part of the systematic review and not part of the recommendations. So what did the committee conclude? Well, they concluded that daily ICS LAMA is an alternative therapy after SMART and after daily ICS LABA for moderate persistent disease only.
Okay.
For severe persistent disease, the preferred therapy is for those kids not controlled on ICS LABA is actually triple therapy. A little hard to execute because there's not a combined device, but it's a high dose ICS LABA plus add-on LAMA and as needed short-acting beta agonists. So now you're dealing with 3 different devices, obviously a bit tricky.
Yeah, you think of sometimes these kids need, at least 2 devices because, taking them for, you want the RN at school to have them. And so I feel like sometimes too, thinking from a practical standpoint, like you're saying, insurance coverage and just compliance is going to be tricky there. When does the expert panel feel that an escalation to immunotherapy is warranted?
Yeah, thanks for that question. The committee wasn't very enthusiastic about immunotherapy and really recommended fairly narrow guidelines. First, a couple of caveats. It was felt that a slit sublingual immunotherapy doesn't have a role right now in asthma therapy. May be helpful in allergic rhinitis, but certainly not in asthma therapy yet. So the focus was on SCIT or subcutaneous immunotherapy. And a number of caveats there: should not be used in severe disease. So really only in mild to moderate disease, and only in those ages 5 and up with, again, mild persistent, moderate persistent disease who desire a drop in their exposure to inhaled corticosteroids. So in some pretty narrow recommendations.
Okay, perfect. When or how, I guess for me too, even with my own daughter, definitely has the allergic viral heavily horrible allergies, but also that when that she gets that virus, it's when her asthma kicks in. But even for me as a pharmacist, I don't feel like I'm well versed in how do you minimize the indoor allergen reduction, and what kind of counseling points do you give your patients?
Oh, this is so hugely frustrating because the literature around allergen reduction, or the efficacy of allergen reduction, is not very optimistic. And the panel's recommendations are not particularly encouraging. They conditionally recommend against efforts for allergen mitigation in the home as part of routine asthma care. And when attempted, they should only be done for those individuals who are exposed to a specific allergen, like the dust mite or cockroach allergen or mouse allergen, and who are sensitized and become symptomatic after exposure. And if you're going to try to do this, really multi-component tailored intervention strategies should be used. So, for example, if you're going after mouse, for example, mouse allergen, you'd want to use a multi-component approach where you try to limit entry of the mouse into the home, control all food and food products so there's nothing for the child to eat. Don't have the child eat in the bedroom where he or they sleep, and really go after it with a big multiple component intervention. But be aware that the demonstrated efficacy of this stuff is poor at best. So not very encouraging, I'm afraid.
No, and I can tell you, embarrassingly, we had some mice and they travel in hordes. They are disgusting. Like, we did everything. They just love to come through our basement somehow. And it's hard because there's like they're little families. Now, new to the guidelines too was how we use the FeNO and how that plays a role now in the recommendations. I would love for your viewpoint on that as well.
Yeah, the good news is it's safe, it's non-invasive, it's pretty easy to do. Biggest drawback is that you have to buy a piece of equipment to do the measurements.
Okay.
In the home. What you're measuring is exhaled nitric oxide, and it's an indirect measure of what we call type 2 or eosinophilic airway inflammation. So FeNO, as we call it, is high in those kids who've got a lot of allergic airway inflammation. Can be tricky because use of ICS, cigarette smoking, allergic rhinitis can all affect the measurements independent of asthma control. So with that caveat, the committee was pretty narrow, actually, Jenna, in its recommendations. They felt strongly that it should not be used alone to diagnose or manage asthma. They could support a diagnosis in older kids, 5 and up, in whom the diagnosis sort of remains unclear after a complete history, physical, spirometry, and all that. And in a subgroup of kids with well-established diagnosis, that serial FeNO measurements, perhaps every 2 to 3 months as part of ongoing longitudinal care, could supplement the history, clinical assessment, spirometry, and ongoing care. But all in all, there was real limited enthusiasm for the use of FeNO in clinical care. It certainly is not emerging as the biomarker which will solve all of our problems.
Yeah, interestingly enough, I had a company that does this, sells the device, actually approached me to see if I wanted to help market it. And I'm like, not really, not if it's not like, supported by the guidelines. And we don't think it's going to make this massive change in the diagnosis and management. But it's definitely, I think too, like we're used to using the traditional, like measuring the FEV, and what I think you can get down to like 8 accurately to measuring it. But this, I mean, my eyes perked a little bit that they can go all the way down to 5. Is that correct?
With the pheno?
Yeah.
Yeah. It's so easy to do. We're doing it on younger kids than that. And spirometry in good hands can be done down really quite young. And there's actually protocols for infants spirometry.
Oh, wow.
Yeah, those are fun to watch.
And then the last thing that was talked about in the guidelines that I had never heard about, probably some of our listeners haven't, was the bronchial thermoplasty. Can you just explain that a little bit and what its clinical utility is, if anything?
Yeah, limited use in adults, and I frankly don't know much about it, Jenna, but this is just what it sounds like. This is done in the operating room. And using heat, the airways of the lungs are heated and dilated. And this provides clinical benefit to a subgroup of adults with asthma that is poorly controlled after every possible other approach is undertaken. It has no role in pediatric asthma.
Interesting. Okay. I think that highlights most of the changes. Stephen, as we end, is there any other things you feel like as either a pharmacist or even an RN or a pediatrician that we should know regarding this update?
Well, again, it's what's not in it that's probably most exciting, and that's what's evolving and emerging right now. And that includes the personalized management of phenotypic specific types of asthma. Asthma, Jen, as we know, it's not one disease. It's lots of different diseases that manifest as obstruction of the small to medium-sized airways. And so tailored use of biologics is going to be more and more the future. And then the really holy grail, and I'm working on an exciting project right now, 2 of them, in fact, is on primary prevention of asthma. So this is identification very early in life of children, infants, even fetuses that are going to be at high risk for the development of asthma based on their genetics, based on their early life exposures. And these are kids in whom we feel we may be able to prevent asthma altogether. And that's using passive and active immunotherapies and actually redirecting the development of the immune system into a more natural anti-infectious direction, a type 1 direction as opposed to a type 2 or allergic direction. So a lot coming on that, and that's the exciting new stuff.
That is so exciting because I know, like personally, with my 3 daughters, like I know my genes kind of set them up to be screwed as far as it comes for allergies and asthma because Stephen, I have like eczema, I have allergies, I have celiacs, I have no IgA. So I'm really just setting these kids up. So that would have been awesome. I mean, even for myself and my own girls too. Yeah, it's really exciting. And even as a pharmacist, I mean, I always wonder too, as this emerging role of pharmacogenomics, it becomes more and more popular. I mean, I use it in all my medically complex kids, and it really helps guide therapy a lot. And so I wonder, if you weave that into just a lot of exciting things in the horizon. I want to just genuinely thank you for your time. I so appreciate it. I feel like I'm talking to a superstar because as a pediatric pharmacist, I'm like, oh my God, I get to talk to one of the authors and expert panel of these guidelines. So I do use them as a Bible. So again, thank you so much. And I genuinely appreciate your time.
Oh, I really enjoyed our time together. Thank you.
Thank you.
That's all for today's episode. Thanks for listening, and remember to subscribe on Apple Podcasts and leave us a review.